Welcome to the McCourt Foundation Neurological Symposium session on ALS. First, I want to recognize and thank the sponsor, Mitsubishi Tanabe Pharma America, for their steadfast support of the McCourt Foundation and the Neurological Symposium, ensuring that the latest updates in ALS treatment and care are accessible to all. My name is Dr. Doreen Ho, and it is my pleasure as Clinic Director to provide updates in ALS treatment and therapies from the Healy Center at MGH. This presentation itself was a group effort with slide credits to a number of my colleagues, and it seeks to provide an update on the clinic first and foremost, and then highlight just a couple exciting areas in the work being done at the Healy Center in collaboration with many partners. These are my disclosures. For background, an overview of ALS. ALS is a devastating and fatal disease. There is a high burden of disease for people living with ALS and their families. ALS is a disorder of the motor system, and painless progressive weakness is the hallmark. There can be, unfortunately, a delay in diagnosis with an average time from symptom onset to diagnosis of 12 to 14 months, and misdiagnoses can occur. The average survival after symptom onset is 2 to 5 years, but there is a very variable course for people living with ALS. Death usually occurs due to respiratory failure. There is no known cure. Currently, there are 3 FDA-approved medications for the US and Canada: Riluzole, Radicava, used for both familial and sporadic ALS, and tofersen for a specific type of genetic ALS or familial ALS attributed to SOD1. The global disease burden is high. In 2015, there were 222,801 cases worldwide. In 2040, there is projected to be 380,000 cases of ALS worldwide. Although painless weakness is the classic symptom, bulbar symptoms such as slurred speech or difficulty swallowing, drooling, and aspiration are common and are very important to identify and manage clinically. Non-motor manifestations can occur, such as pseudobulbar affect, which can be characterized as sudden outbursts of involuntary laughing or crying due to loss of voluntary control of brainstem centers, depression, fatigue, weight loss, pain, and cognitive changes, to name a few, which are very important to recognize and treat. In many ways, ALS is really a multisystemic disease. Multidisciplinary clinics like ours provide longer survival and better quality of life for people living with ALS, as they can respond to the evolving needs of people living with ALS. There is no one provider in the ALS clinic, but instead a team working together and addressing the different needs of patients and families in a holistic manner and a highly individualized approach. At our clinic, over 900 people living with ALS are seen annually. Each person living with ALS has one physician, one nurse practitioner, and one RN. We see our patients in Boston and Waltham. We provide telemedicine. The Daniela Lipper Parenting at a Challenging Time, which originated from oncology, is a psychoeducational program that seeks to offer guidance to parents and grandparents on communicating ALS challenges with children and young adults. The ALS Daniela Lipper House Call program is led by advanced nurses with the goal to bring expert and individualized care to people living with ALS beyond the clinic in order to reduce isolation and increase partnership between MGH and community organizations. People living with ALS also have opportunities at MGH to participate in research, whether clinical trials or biomarker observational studies. We are a coordination center as well for consortium of ALS trials called NEALS and for the NIH-sponsored Network for Excellence in Neuroscience Clinical Trials, NeuroNext. The incidence of ALS is 2 to 4 per 100,000 and the prevalence 5 per 100,000, with a worldwide incidence and prevalence being relatively uniform Male predominate over females 2 to 1, and the average age of onset is 55 years old. The onset before age 30 is uncommon but can occur, and familial ALS accounts for about 10 to 20% of cases of ALS. And in those situations, usually there is an autosomal dominant inheritance pattern. In general, with ALS, where we want to be is to slow and stop ALS, and this may involve a group of medications, which we'll talk about a bit later. We want to prevent ALS in gene carriers who are at risk, and we want to reverse ALS. In terms of the current state of approved treatments for ALS in the US and Canada, there are currently 2 approved treatments for sporadic ALS, the first being Riluzole and the second being edaravone. These can both also be used in familial ALS. Qalsody, which is delivered intrathecally, is also approved by the FDA for a genetic form of ALS due to the SOD1 mutation. And in general, in our clinic, we do recommend the disease-modifying treatments and discuss the side effects and the data with our patients. So we'll talk about each one individually. Riluzole is the oldest disease-modifying treatment approved by the FDA. The mechanism is complex, but in part, it is an anti-glutamate and reduces excitotoxicity. Riluzole has been shown in pivotal trials to have a survival benefit in people living with ALS. And there is data to show that from the early pivotal trials that treatment with Riluzole showed increased survival, as shown in sort of the spread of the curves, with the red being placebo and the green being 100 milligrams of Riluzole per day. But this was mainly demonstrated in later stage disease and stage 4 disease. The treatment did not show effect in earlier stage disease. However, in follow-up studies, for instance, in Thacker's study involving 4,778 patients from the PROACT database, 3,446 had received Riluzole, and Riluzole improved survival uniformly, and delaying initiation by 1 year may translate to reducing median survival by almost 2 months. So for that reason, generally we recommend initiating Riluzole earlier. In this paper of real-world evidence by Jinsey Andrews, it also demonstrated survival benefit ranging from 6 to 19 months based on real-world data. Based on some of this data, we do recommend Riluzole in our clinical practice. We monitor liver function tests, ensuring that there is no asymptomatic elevation or liver injury in our patients. There have been a few cases of neutropenia, so we also follow early on, follow the CBC. In general, cost has been and access for patients has been good. The drug has been well tolerated without major side effects, and typically we do offer and recommend the Riluzole early in disease. The second medication is edaravone, which is a free radical scavenger to reduce oxidative stress. It was approved in an IV form and then a PO form based on bioequivalence data. And in a phase 3 study, the impact of edaravone on an ALS FRS in a post hoc analysis of patients with earlier stage disease and definite or probable ALS did show a benefit from edaravone. There was no known impact on survival. This just demonstrates the difference in ALS FRS. This medication can be used synergistically with the Riluzole. In general, it is well tolerated. Side effects include gait disturbance or headache. Usually it's prescribed in the by mouth form. Cost and access have been issues for certain patients, and it is used in caution in patients with asthma. So those are the 2 disease-modifying treatments used for sporadic and familial ALS. The third agent, which is tofersen, is specific to SOD1 mutation associated with ALS. It is intrathecally delivered. And based on a clinical trial, it was approved for accelerated approval for SOD1 ALS in March of 2023. And the first Calcity clinic at MGH was launched in June of 2023 and is now a very active clinic. It is led by doctors Suma Babu and nurse practitioner Jen Scalia. So that provides a bit of a clinical update on the ongoings of the ALS clinic. And I want to move to highlight a few new exciting areas of research at the Healy Center. As we think about innovation in clinical trials, it's important just to recognize that no two individuals living with ALS are the same, and there's quite a bit of what we call heterogeneity, meaning variability in terms of genetics, the biology, and also how patients present, clinically what their story is and what their symptoms are. Over 50 genes now have been identified, and this lists the most common genes. And a causative gene, as in the example of SOD1, may be a target for potential treatment. However, most patients do not have a known genetic mutation, and there's likely an interplay between a patient's genetics and an environment in the development of ALS. Biologically, there are probably more than one mechanism, multiple mechanisms converging on the end pathway of upper and lower motor neuron death. And factors that affect clinical trials are, as mentioned, the variability of the disease, trial design, resources, outcome measures, and biomarkers, and also biological understanding in the disease. And here are some measures to improve clinical trials, not just to have more trials, but also to improve the current clinical trials. And research into biomarkers, be it serum, CSF, or urine, imaging, and electrophysiologic biomarkers. So I would like to highlight an area of innovation in clinical trial design. Historically, most trials in ALS had been conducted with traditional fixed designs. And the goal is really faster and more patient-centered trials that can help to develop a deeper understanding of ALS and allow for more efficient, flexible, and inclusive trials with the idea that all patients with ALS will have access to research if they wish to engage in research. The Healy Platforms study trial is a first of its kind perpetual adaptive trial in ALS. In general, looking back, it was estimated that fewer than 5% of people living with ALS in the UK and 8% of people living with ALS in the United States was in a clinical trial that involved an investigational product during this time, as shown on this graph. So there is a need for more access to trials for patients if they wish to engage, which allows for partnership, expanded access protocols, and based on this, the Healy platform study led by Drs. Sokovic and Paganoni was designed. And there's also a need for training more and more site investigators, physicians, and nurse practitioners in leading these trials as well. And the drug pipeline in ALS is very robust. And this graph also shows the platform trial's role in increasing the number of trials in this disease. The platform study is an innovative trial design in that rather than creating a new structure for every new therapy, as would be the case for a traditional trial design, the platform maintains the same structure and brings in novel therapies quickly to test them under the same infrastructure. At this time, there have been regimens A through G that have gone through the Healy ALS platform study. These new investigational products are brought in quickly with the same structure that can be modified to allow for new biomarkers or new outcome measures to be added, and then investigational products are tested to determine whether or not they can sort of so-called graduate to phase 3. And as you can see, to a potentially graduated to phase 3. And this allows a very adaptive design, a perpetual design, and allows vetting of investigational products from phase 2 to phase 3. So a very efficient design. This slide by Dr. Paganoni just shows basically sort of the design of a study, and it's very patient-centered. So every patient will go through a screening period and then a placebo-controlled period, and then what's called an active treatment extension, where every patient would receive the active investigational product. And there is also a reduced number of patients in placebo in this study, which allows it to be patient-centered in that way due to sharing of placebo. The second area I just wanted to highlight as well is observational studies, which is a very exciting area. Currently at the Healy Center, observational studies fuels investigational studies and leads to a deep understanding of the disease and development of new tools and biomarkers. Answer ALS was a study conducted at 6 sites, then enrolled 1,000 patients and control subjects and created a large amount of biological data to help discover ALS causes and accelerate discovery of treatments. All ALS, which stands for Access for All in ALS, is a very exciting, large-scale project funded by the NGH and by the NIH and at MGH, led by Dr. James Berry, and this is being integrated into our clinic to help us learn more about ALS. This is being rolled out in the clinic starting this month. It's very flexible. Patients can be enrolled remotely, and the goal is to enroll 2,000 patients quickly to learn as much as possible about ALS, fuel studies, expand outreach activities and communication, and expand engagement. And this is a very exciting piece of the work that's being done. So in summary, this is a truly very exciting time in ALS clinical care and research. Current FDA-approved disease-modifying medications are Riluzole, Radicava, and Tofersen for SOD1 ALS. I didn't have time to talk in detail about Nuedexta, which is FDA approved for the symptom of pseudobulbar affect. Many novel therapies are in the pipeline. Discovery of genetics has led to precise targeted approaches, and novel trial designs and large-scale observational studies are critical to the path forward. Expanded access and partnership with the community of people living with ALS is essential to a new reality where every patient living with ALS has the opportunity for a clinical trial or study if they do wish to participate. Thank you so much for your attention. We are so grateful to donors like the McCourt Foundation who allow the Sean M. Healy and AMG Center to be nimble in pursuing the most cutting-edge research and therapy development, as well as to offer people living with ALS personalized care options. And thank you very much for your time.